Hi, folks, and welcome to First Bite, Fed, Fun, and Functional, a speech therapy podcast sponsored by SpeechTherapyPD.com. I am your host on this nerd venture, Michelle Dawson, MS, CCC-SLP, CLC, the All Things Peds SLP. I am a colleague in the trenches of home health early intervention right there with you. I run my own private practice, Heartwood Speech Therapy, here in Culvertown, South Carolina, and I guest lecture nationwide on best practices for early intervention for the medically complex and fragile child. First Bite's mission is short and sweet, to bring light, hope, knowledge, and joy to the pediatric clinician, parent, or advocate.
By way of a nerdy conversation, so there's plenty of laughter too.
In this podcast, we cover everything from AAC to breastfeeding,
ethics on how to run a private practice,
pediatric dysphagia to clinical supervision,
and all other topics in the world of pediatric speech pathology. Our goal is to bring evidence-based practice straight to you by interviewing subject matter experts.
To break down the communication barriers so that we can access the knowledge of their fields.
Or, as a close friend says, to build the bridge.
By bringing other professionals and experts in our field together, we hope to spark advocacy, joy, and passion for continuing to grow and advance care for our little ones.
Every fourth episode, I join in. I'm Erin Forward, MSP, CCC-SLP, the Yankee by way of Rochester, New York transplant who actually inspired this journey. I bring a different perspective, that of a newish clinician with experience in early intervention, pediatric acute care, and nonprofit pediatric outpatient settings.
So sit back, relax, and watch out for all our squirrels and enjoy this geeky gig brought to you by SpeechTherapyPD.com. Hi, my name is Michelle Linwood Dawson, and these are my financial disclosures. I am the author of Chasing the Swallow, Truth, Science, Hope for Pediatric Feeding and Swallowing Disorders, for which I receive royalties from the sale of. I receive compensation from SpeechTherapyPD.com for CEUs associated with the book, for this podcast, First Bite, as well as for numerous other presentations. I receive compensation from PESI for one course that I have with them. I receive an annual salary from Wolf Speech Therapy Plus LLC, as well as in my capacity as adjunct professor at North Carolina Central University. And I receive profits from the sales of First Bite Boutique sweatshirts and t-shirts that Erin and I design that is not affiliated with First Bite, the podcast, which is sponsored by SpeechTherapyPD.com. My non-financial disclosures. I am topic chair for the Pediatric Feeding and Swallowing Disorders for ASHA for the 2024-2023 convention. I am the chair of the special interest group, or co-chair of the special interest group for pediatric feeding disorders and dysphagia for the Speech Language Hearing Association of Virginia. I am a convention committee member for the Speech Language Hearing Association of Virginia. I am a member of the Speech Language Hearing Association of Virginia. I'm a board of trustee member with the Communication Disorder Foundation of Virginia. I'm a former treasurer with the Council of State Association Presidents, past president of the South Carolina Speech Language Hearing Association. I am a member of ASHA, ASHA SIG 10, ASHA SIG 13, SCISHA, Dysphagia Research Society, National Foundation of Swallowing Disorders, and the National Black Association of Speech, Language, and Hearing.
Okay. My name's Erin Forward, and here are my disclosures. Financial disclosures. I receive a salary from Cincinnati Children's Hospital Medical Center. I am the owner of Forward Education LLC, where I do courses. I receive royalties from Speech Therapy PD for this podcast, First Bite, and other presentations as well. I am also a owner of First Bite Boutique with Michelle Dawson and receive compensation for that, which is also not associated with First Bite podcast, sponsored by Speech Therapy PD. Non-financial disclosures. I am a contributor for the book Chasing the Swallow by Michelle Dawson. I am a member of the South Carolina Coalition for DIR Floor Time. I am a member of ASHA and SIG 13, as well as Dysphagia Outreach Project and Feeding Matters. And I think that's it.
Huzzah! Thanks, y'all. Thanks for sticking around to listen all the way through to the disclosures. Yay!
The views and opinions expressed in today's podcast do not reflect the organizations associated with the speakers and are their views and opinions solely.
All right, everybody. I always say that at the beginning of every episode. One day I'll say something different. Chadwick, I do listen to you. But anywho, y'all, I am straight up excited, overwhelmed, and fangirling because we have none other than, dare I say, the Heidi Moreland with Thrive by Spectrum Pediatrics. And y'all, she is so highly respected within our field of pediatric feeding and swallowing disorders, but not just for her contributions, but also for her kindness. And that is kindness and compassion for colleagues, for caregivers, and for the tiny humans that we've been called to serve. And she has touched the lives of more of us than we could probably ever count through her numerous works. She has contributed to several publications, including Responsive Feeding, the White Paper, Love Me, Feed Me, and Adopt a Family's Guide to Responsive Feeding, Case Studies in Pediatric Feeding Disorders. She travels nationally to talk. I know she has an upcoming talk at ASHA, which I was a little excited about, and also has hosted a podcast. And so all the things. So Heidi, thank you so much for coming on.
Oh, I have been so excited to come. So I have just been looking forward to this for a while, and that was such a kind introduction. So thank you so much. I'm looking forward to this.
Yes. Okay. So I always like to get people's backstories. How did you decide to become a speech pathologist and then one that specializes in our world, which does involve poop and boogers and vomit and sometimes gross things? So take us on the journey, ma'am.
Sure. I started out as a teacher, and I loved my little people. I was a preschool teacher for 6 years in the public school system. They were for kids who didn't quite qualify for special ed, but they weren't quite meeting all their milestones. So that middle ground is where I worked. And I loved those little people so much. And then after 6 years, I was getting kind of tired of the bathroom, taking them to the bathroom and doing all those things. Like I love seeing their little minds work, but I just, the day in and day out stuff, I didn't actually, I was starting to get, like I loved my units that I put together, like all the thinking. But once you've done it a couple years in a row, it's kind of set up and then you're just running the program. And so I wanted to work a little bit more with those kids in that way, which I loved. And we had an amazing speech therapist in my first job. And I thought her brain was so cool. And then we had one that wasn't as great. And I was like, well, shoot, I could do that. So I just applied to UNC, which was down the road for me, and got in. And I thought I loved speech. I love feeding because it seemed black and white to me. Like it was not murky like child language. And so now that I'm in feeding and swallowing, that has to make you laugh because feeding has to be like the murkiest, gray, wandering around in the weeds specialty of just about anything that we do.
Yes.
And I love it. I love the difference you get to make in families, in kids, like uncovering their capabilities within those little bodies. It's just the best.
Yeah.
So that's how I got here. I thought I was going to do kids with hearing deficits and work in a school for the deaf or something. And then I worked with adults, and now I'm here in just the murkiest place of all.
Yes, it is. I started out working as a speech teacher. I think that's what my original cert said a lifetime ago in the public schools. And I had a deal with the preschool teacher that if one of the, the little ones that qualify for speech but don't qualify for the ECIC classroom or anything, if they came in, because the bus would drop them off and they had a wet or poopy diaper. I mean, this is me pre-children. I cannot touch that. That is so gross. So I would buy her coffee for every diaper she changed. And that was, I bought a lot of Starbucks a lifetime ago. But that's how I knew I couldn't stay in the public schools because I couldn't be responsible for
Yeah.
Yeah, but I did actually have one little guy who went into the bathroom, and we would use her bathroom because they were the right size. And
Yeah.
he didn't put the toilet seat up all the way, and it fell on his tallywhacker. And we both heard it happening, and I was like, oh my God. And then after we calmed down, I was like, I can't do this. And she's like, hurry up and graduate. You're almost done. I was like,
Yeah.
it's fine.
My story with that is the exact opposite. Is when I was a teacher, I was telling this little boy that he needed to stand on the stool or let me help him because he was not quite tall enough to like aim in the potty.
Yes.
And he was so insistent he was going to do it himself. He was up on his tiptoes and teetering. And I was like, okay, do it. But then he lost his balance and it hit the rim and he peed in his face. And I was like, I love natural consequences. They just work out. I mean, the little guy, he's old now. He's in high school now, I'm sure. No, actually, he may even have kids by now. I don't even know how old he is. But it was sort of the opposite. I was like,
that's okay.
Natural
Right.
consequences.
One more funny story. Ultimate mom fail. We were in the middle of the pandemic, and we were at Rosewood Market, which is a little mom and pop family market in Columbia, South Carolina. And a bear was in line with me, and he had to pee so bad. So he went into the bathroom, and he came out with his mask off. And I was like, buddy, what are you doing? Where's your mask? And he whispered in my ear, he goes, I peed on my face. And to this day, I have no idea. Child peed on his own face. And so I'm standing in the checkout line. I was like, you peed on your, and I said it just as loud. And there was a little woman, probably in her 80s, with all white hair, a bouffant. You know what I mean? Like, done styled,
for sure.
Styled in place twirls. And she goes, oh, honey, all of us boy mamas have that story. And I was like, oh, God, get me out of this grocery store. So
it happens. And now you know how.
Yes.
It's the balance.
It's the balance there. Now I will now know. Okay, this derailed right out the gate. Hi.
Hello. It's good to see you.
Good to see you. Okay, so now you've kind of been, so you were in North Carolina, then you went to Georgia, and now you're in Mexico. Can you tell us kind of a little bit about the settings?
So I started in North Carolina in the school system there. Actually, I started in Illinois in the school system. Then I went to North Carolina in the school system. And then I went to grad school at UNC, worked at UNC hospitals for a couple of years.
Cool.
And I did a little everything there. I worked with Chrissy Brackett, who is my CFY supervisor, who's awesome.
She's brilliant. I
love Chrissy.
Adorable. Yes. Y'all, if y'all haven't, she just got her PhD or is finishing her PhD. Yes.
She's done. Yeah.
Yes. And her research, y'all, she has Christy Brackett, AEIOU, I believe is the name of her course that she'll teach.
Yeah.
Yes, folks, highly recommend. Yes. Okay.
Yeah.
Continue. Sorry.
So she was my CFY supervisor, which is how I started to get into pediatric feeding and started seeing whole child stuff. And of course, then I listened to Marsha and I listened to San Evans Morris, and I started getting more and more that way. Well, they had a CFY program at UNC that you could stay in for a year, and I actually stayed for 2 years. But then I had to get a real job, and I went to Children's Healthcare of Atlanta. I was in Atlanta for 15 years and did almost exclusively feeding and swallowing, a little NICU, lots of swallow studies, craniofacial clinic, like all the feeding stuff. I was almost, the majority of my stuff was feeding and swallowing stuff on all the levels. And then I was starting to see all these kids that I was like, they're walking, they're talking, they're using their mouth. It doesn't make sense to me. Just because they have a feeding tube, their chewing doesn't work. Like not all these kids have a diagnosis that would mean their chewing didn't work. And I had a family who found then Spectrum, now it's Thrive by Spectrum, on the internet. And she was like, what do you think? I was like, I think it looks awesome to do this intensive tube weaning program. And you should go, and I want to go with you. So they went for the 10-day program, and I went just for the weekend and met Jenny, who's now my boss. And we had both sort of come to the same conclusion. She had done that first and worked with Graz, and it just connected some of the dots for me on how the motivation piece of it, how the understanding of food piece of it played a role in their eating, and just the really big importance of the kid being in the driver's seat and the kid being motivated to do it. Yes. And so I kept bugging her for training, and she finally was like, I don't have margin for training. Do you want a job? So I left Children's and I have been at Thrive. Since then, I lived in Nashville, Tennessee, and now I live in Southern Illinois outside of St. Louis, doing the same thing, coordinating the tube-weaning program and treating kids and doing some teaching and training and publishing and that kind of stuff, or like research. So that's sort of a long, windy journey.
Yes, but you've been able to see PFD and its evolution from PEDS dysphagia to actually having the 4 domains of pediatric,
absolutely,
which is, y'all, and I know we've talked about how much we love Feeding Matters here on this podcast, but please, please, please go to the Feeding Matters website and see the resources they have that break down the 4 domains. Because if you're not doing it yet, please document according to the 4 domains in your EMRs. And if you're in a private practice, lots of your EMRs can be customizable and they'll do it for free. If they ask you to pay them for the changes, try to negotiate that, because most of the ones that I've worked with, if we're willing to put forth the effort, they'll customize it. I've been able to get we have Quick EMR. It's completely customizable to the template that I need. And that's life-changing. Yeah.
All of these little people are big, but like, we were just talking about this. I just thought I was going to be working with feeding and swallowing because it was so simple and it was just a swallow. Goodness.
No.
These little people are complex people.
Yeah.
And they live in a complex family who's been sort of, the majority of the time, derailed in one way or another. The part I wrote in the case studies in pediatric dysphagia was actually about trauma. And I can't imagine a situation when there's dysphagia, when there's not some kind of trauma to the family's emotional expectation of what meals were going to be like, to the kiddos' experience with food, to actual, swallowing unsafety and what that does to the body. But what does that do to their sense of safety as self? What does that do to the parents' identity as a provider and a caregiver and a nurturer for their baby? Not to mention just what they expected to have at Thanksgiving dinner. Like all those domains play a role in that tiny little body, and it's too easy to forget all those pieces.
So before we got on, her and I were having sidebar conversations, or I guess it wasn't sidebar, it was prep work conversations, like what we're going to cover.
Yeah.
And guys, one of the things that I see, and I have streamlined my social media account. So like it's pretty much a home design, pets, and a few close friends, because I just can't see what is really going on in the world, because it's sometimes traumatic and scary to watch. But the world of pediatric feeding disorder and PEDS dysphagia is incredibly complex. So if you're on the world of social media and you watch one 30-second reel or tick of the talk, and somebody is providing evidence, quote unquote, please give it pause, because just as Heidi said, these kids are incredibly complex. So unfortunately, I often see one research study being misconstrued or presented as overgeneralized, and that can cause harm, especially for a novice clinician, somebody that's seasoned, gray-haired, but just entering the world of PFD, but also that caregiver that's looking in the middle of the night that just want answers for what's going on with their babies, and they see somebody with a cute little dance and a cute little reel and they latch on to it. So please proceed with caution with your social media consumption. That's a pretty way of saying that, right?
It's a pretty way of saying it. And I think it's everybody wants to help.
Yes,
everybody wants to help.
So.
In our tube-weaning program, because we're a program that everybody finds downstream, we get kids from all over the country, really all over the world, and they've tried everything that's in front of them. They've tried all the people they've been referred to. We've gotten kids from probably most of the states in the United States. They're all affiliated with a children's hospital. And I was affiliated with a children's hospital. I loved working at the children's hospital. I was there for a long time. I knew lots and lots of things. I worked with lots of professionals who lots and lots and lots of things. But I also found when I switched to working in the homes like this, that I didn't know that person as well as I thought I would, as well as I thought I did. They get lumped into feeding PFD, and there they sit. And to the doctor, they're a G-tube kid or a tracheomalacia kid or a kid with, whatever box you pick. And we know those specialties really, really well. And we want to help. And that's the tool that we have. And so that's the tool that we bring to the table. And because the attention of the world is getting smaller and smaller and shorter, we try and put them in little bites, forgetting that when you're the mom who's trying to put all those pieces together, you don't have the framework that makes those little tidbits helpful.
Yes.
We need, as professionals, to continue to build a really good framework for that feeding relationship and that safety relationship. I say frequently that we are communication specialists.
Yes.
We are the best at communication, and yet we don't always do as great of a job of building that relationship with parent and child as we could, because we kind of assume the parents are reading the cues, or we feel like this thing is more important. But truthfully, if I put myself down to it, my primary job is supporting families to become families. Whether they take another bite or not, my job is to heal whatever has gone on in that relationship. The feeding will come from that. But my job is to help their communication and their connection first and foremost.
The attunement and the attachment. I feel like
Sure.
90% of 46% of what I do, I feel like, is championing and navigating for referrals to get in with the specialist. And then the other bulk of that is attunement and attachment.
Right.
And
absolutely.
And that's something that academically, if you didn't have a class in early intervention, or if you didn't have an early childhood language class, you might not have learned about the theory of attunement and attachment.
Right.
But that also piggybacks into what you said earlier about the trauma. And so much of this is the trauma responses that they're seeing. We're seeing the results of all of that heartache and grief. Yes.
Yeah.
Boy.
Yeah.
We get to help heal.
I mean, it's just, we do. That's actually the best part, is that healing is always possible. Always possible. And because so many parents too, when they realize some of the stuff, the decisions that they made because they had to, you had to make a decision, feeding tube or no feeding tube. And then sometimes they get the feeding tube and throwing up gets worse, and all of those other pieces and more digging needs to happen, or the feeding schedule was off or whatever. And they carry a burden because they made that decision. And that's part of our job too, is saying, number one, healing is always possible. And number two, you have always done the best thing you could with the information that you had at the time. And now that door is closed. We're done with that. We've learned our lesson from that. What's the next thing we're going to learn? What did we learn from that? Door closed. Now we're on to the next. And that's super powerful, I think, for a lot of families, is freeing them from that middle of the night loop. If only I hadn't, or if only I had, because we don't have crystal balls as much as it feels like we do or should. Never feels like I do. As much as it feels like I should. I do not have a crystal ball, and I make decisions all the time that I wish I would do differently.
I actually do have a crystal ball from
Can I have one?
So it was a paperweight that my husband got from an employee, and he gave it to me.
Yeah.
And so I used to tease Bear that I could see the future and I would know what shenanigans he was up to. And so
that's awesome.
For a while there, he would go to mommy's crystal ball, and he would be like, I see milkshakes.
That's fantastic.
I'm going to send you a picture of my crystal ball, because
please.
But, I mean, it doesn't quite work as well as it should, unless it's solely designed for reading when milkshakes and cheeseburgers will happen.
Yes. It is a very specific crystal ball.
Yes.
Yeah. So I think we come in our program. So we have, just to back up a little bit, our program gets kids from all over the country. We do an eval. We really look at all the things this little person is telling us and make sense. Like, do we need more medical information here? Do we need to de-escalate a little bit there? It's kind of amazing what a rest from feeding therapy will do. what a rest from the work of food for somebody who's worked so hard their whole life. Sometimes all we do is say, you know what? Take a rest, guys.
Yes.
Take a break. So that when we go into our intensive program, which is 10 days long for the intensive and then a 6-month follow-up, is we get the benefit of hindsight almost every time. Like we get all the medical records. We look back and we're like, oh, that's where that one went awry. Yeah. I see now. And that hindsight is so helpful in saying, okay, here's where some of those things, here's because most of the kids have had every test in the world and they're still having these problems. And so we get to like wade through and get to see where more medical information might be helpful or where it's time to just let that aside and start working on the healing and the peace. So that's helpful from our program. And now I forgot where I was going with that point, okay. But it is a retrospect that's helpful.
So I was of the opinion, and bear in mind, Botox, gray hair, due for some touch up in the back here. Feeding tubes were bad. That's how I was trained. I did not have a peds dysphagia class. I had one night in my grad class, and it was just, you're doing what you can to prevent a feeding tube from getting placed. And having to undo that thought process to understand that for some of our little ones, a feeding tube will be an ally. For some of them, because of their cardiac, cardiopulmonary, metabolic, genetic, whatever conditions, they may require a feeding tube for all of their meals, and we can work on quality of life, pleasure feeding. They may require it just for overnight. The continuum is there, but getting in the mindset that it's not the enemy, right? But at the same time, there are those who have it who may not need it.
Right.
And that was such a, I can feel it in my core. It was like this eye-opening fundamental shift that I feel like a lot of clinicians have to go through and be mentored through. And the first time I read about anything, I always thought it was called the Grodsky Tube-Weaning Protocol.
Yeah.
But how do you say it? Grades?
Graz. I don't know if that's right. I've always said Graz.
I mean, I can speak English and bad English, and multisyllabic words like eosinophilic esophagitis kicks my butt regularly, so I have to practice it.
Right. Because it's.
But that was the first place where I learned anything about, I guess, for lack of a better phrase, the screening protocol to go into what's appropriate, what's not appropriate.
Right.
So. What are your thoughts? How do you tease through and coach out when it's appropriate to go through tube weaning versus when it's not?
Right. So for our evaluation process, we did start similar to Graz. We did work with someone who had worked at Graz for a while, and now we've gone on a pretty significant evolution since that time. At that time, we felt like hunger's magic. And now we know that there's obviously so much more than just hunger, and the responsive feeding white paper lays that out beautifully. I was so fortunate to be a part of that team that worked on that, because I just think it just really looks at all the domains so well in terms of healing your relationship with food. So for our program, you have to be at least safe with one consistency. Awesome. And you need to be medically stable. You need to, for most of the kids, if they're having a pending heart surgery coming up, that's not the time to work on this. There are some developmental windows that we all know about that if we could, we would love to get kids working on this between, 8 to 15, 18 months of age, because that's when developmentally you're learning to eat, and it dovetails beautifully. That doesn't mean it's helpful to push a kid faster than they're ready for. And again, we get kids from all over the country at all kinds of different ages, and there's no good way to study this. But I feel like if I could wave a magic wand and have every kid come in within 3 to 6 months when they were medically done with the tube, because then suddenly they're feeling good. They're feeling, they're ready to eat well. I will say vomiting for us is not a hard stop, because we all know kids who are on tubes throw up more. They throw up more easily. And if we're waiting till the throwing up stops, we're going to be sitting here for a long
Yes.
time. So the screening process for us is really talking to a member of the medical team. We always talk to the pediatrician is often the best person because they know the whole person, the whole little person, whereas GI tends to know their GI system pretty well. So whenever possible, we work with the pediatrician. Sometimes there's a specialist for whatever reason, a transplant coordinator, whoever the specialist might be. But they also are not the ones who know the whole picture really well. That's not how they're set up. They see too many kids. Like, I feel like a medical home makes a lot of sense for kids. And if the pediatrician can have all the information to the best of their ability, it makes sense rather than having the parents be a medical coordinator. It's nice if there's a medical person who can do that for them. So we always talk to a member of the medical team, or like, if they were an eater, would they still need the tube? If they were cooperating, if they were participating, I think we've had kids who are autistic go through the program. We've had kids who have pretty significant motor deficits with CP, whatever. You can be an eater and
Yes.
be all of those things. That doesn't mean you're going to eat every food. And that doesn't mean that you're going to eat every calorie that you need.
And there's grace in this.
Some kids, like you said, some kids are going to need the tube for a long time, and that's okay. But I would also love, one of our goals is let them do as much as they possibly can themselves, and we'll support them, which is the intent when a lot of those kids get sent home, right? Like, we see tons of kids who are discharged from the NICU and they go on to become an eater, just easy peasy all by themselves. Or their parents are just really savvy and they do that. I've got some stories about that too. But I think that if they're well supported, if all the stars align, if things go well and the tube doesn't cause them more vomiting, all those pieces go well, that most kids can become an eater at some level. If it's safe, if they're not aspirating.
So you said autism and our little ones, and I am choosing my words ever so carefully. Yes.
You're right. Yeah.
I have had the pleasure over the years of working with lots of little ones that have autism as one of their diagnoses. Not necessarily the primary etiology, but it's a component, right? And to me, it's been really cool to watch the shift and it being a disorder to a difference in the neurodivergence, neurodiversity frames.
The way you eat.
It's been awe-inspiring to watch us go from dictating what tiny humans eat to respecting autonomy and selection and facilitating opportunities for exposure and experience to more foods in a positive, healing way.
At their comfort. At their initiation.
And Lord Almighty, we all know that the greats in the field are paving the way, like all the work that Marsha's done, Klein's doing to like elevate the autistic voices. I mean, like there's pen clicking in the background because I'm so worked up about it. But I also see where some of our friends have had traditional ABA as well. And they come with the trauma of exclusively behavioral-based approach, right?
Right.
And please note that, I mean, I've met ABA SLPs that are more of a floor timer that have engaged in new ABA. So I know that ABA runs on a continuum. I'm intimately aware of this. So people don't shoot the messenger or throw tomatoes at me because I'll turn them into sauce. But Erin, that was a joke for you. Yes. Sorry. We have a running joke about Italian sauce on Sundays. But the question becomes, in intensives, where is intrinsic motivation versus behavioral base? Because that's been a worry that I have seen for some of our, especially autistic friends, when they're going to consider that.
For sure. For sure. So our program, because of the intensive nature of it, because of the 10 days, we have found for some of the, especially the older kids who are the older neurodivergent little kiddos who've learned a whole lot more about their body already, who've had, whether intentionally an ABA program or just life that doesn't isn't designed to accommodate the way they think, is that our goal is to, again, we do reduce what
Yes.
goes in their tube to see what we can do to get
Intrinsic.
hunger, which is kind of amazing. It's not magic, but it is a very natural, pretty significant motivator to eat. But that doesn't mean, but you also have to remove the pressures. You can't tune in to what your tummy's telling you.
Yes.
If you're anxious, if there's external expectations on what the food you're going to eat is going to be, if you're in an environment that doesn't support the way your brain works, and really the biggest thing is fear and time, I think. They're not going to necessarily do it quickly. We have found that whatever supports you need outside of mealtime, you might need in mealtime. If you need a schedule of things that you can expect happening in your day, we go to school at this time, these things happen. If it helps for you to have a knowledge of what's coming, then it might also be helpful for you to know that this is lunch and these are the things that are going to happen. Like just really putting in whatever supports and not pressures. By supports, I mean what truly does help them get through their day, not how can we tell them what we expect of them, which is two different ways to use a social story and two different ways to use a schedule. What supports do we need to put in place to help them navigate this, to connect the dots? Because evidence, like they can't, whatever your diagnosis, everybody has an internal experience. We don't know what it is. You can never know somebody else's internal experience, but we can be curious with them and navigate them to help them figure out what their internal experience is and what that means for them. And so we do support the kids differently depending on how their body seems to be working. And it is more difficult once you've had a significant number of external experiences that have undermined what your body's telling you. Like a really clear example of someone who is in college now and a ballet dancer. Like his mom sends me pictures of him. He's studying ballet in college.
Which requires a lot of calories,
but
by
he was
the way.
allergic.
Having been a former dancer.
It requires a lot of calories. So I saw him obviously many, many, many years ago. And he had just completed, when I saw him, he had just done an ABA program where they didn't know that he was allergic to dairy. So he would eat every single day. They would make him eat food. He would get in the car and throw up every single day. And his mom was in tears, obviously. So we spent a lot of time working on, I still did more external rewards than I would have now. I still, full disclosure, when I was in the hospital setting, I did things differently than I would do now. We all learn, we all grow. And he learned that food makes me sick. It was not supported in the way that supported his internal experience. Nobody knew how his tummy felt. And so if we had that time, obviously I saw him after that, so I didn't have to navigate that area, but we could have, as medical providers in general, helped him navigate how that made him feel and let him heal from that. That's a really obvious one, that milk protein allergy and vomiting. But what about the fear-based stuff? What about your mommy being asked to leave the room?
Why?
What about big people you don't know?
Every feeding session I've ever done, I've always had the caregiver in the room for the duration of. I may be modeling a strategy or having a caregiver hold the baby and I'm correcting positioning, or if we're exposing and playing with food, then the caregiver is doing it with us. I have one little guy who I just saw 2 Fridays ago. Oh, bless his heart. He's really into albino creatures right now. And we brought in broccoli and we were painting, because we were painting with white, because I'm playing on, you want to talk about albino things?
Yeah.
We're going to talk about albino things, man.
Yeah.
So painting with ranch and it's green broccoli. So he started talking about albino crocodiles. And I was like, you know what I heard? I was like, Bubby, Shell heard that alligators, especially albino alligators, they really like some broccoli. That kid turned the thing around and took a big bite. And the mom goes, they really like broccoli? And I was like, and then she read my face and she goes, they love broccoli. And then she and you know what? We paired something that made him really happy. Now, did I ever think in a million days he would bite the head off that broccoli? No. I just, it worked. And you know what? That kid was like, this is yummy. And so he started dipping. I mean, I think honestly it was the ranch that was yummy, but I mean, ranch
I'm
is
sure.
delicious,
Yeah.
but we play a lot with condiments, but it was just so funny because it was, I don't know what Bubby's been through, right? I call them all Bubbies, but like, yeah.
Well, and one of the lovely things you just did was take something that was unknown or
Beautiful.
scary
Yes.
and make it familiar and meaningful and fun. And I think that's one of the things. So, in the responsive feeding pro stuff, we're redoing the foundational series on responsive feeding. And one of the things we're talking about is competence and how important a feeling of your own competence is. Like my feelings matter
Yes.
and my no matters. And so we talk a lot about letting them say no. And as a young therapist, or even when I wasn't so young anymore, I was like, what do you mean I'm setting them up to say no? Like, that's the exact opposite of what I want. But really, that allowing their no to matter meant you matter. And because you matter and you have an opinion, that opens the door for other experiments. And I think that gap of time of allowing a no and allowing a break is kind of scary as a clinician. And yet that healing piece of saying, you know what, if he hadn't put the broccoli in his mouth, if all he did was say, yay, alligators like broccoli, that still would have been a dot that was connected, that took it from scary broccoli to white broccoli.
Yes. Yes.
Because it's albino. And it was still moving it a little closer from the yucky, scary side to the this might be okay side. Like, it doesn't all jump over all at once. It doesn't for me, for heaven's sake. I don't learn that way. And so letting them have that no, letting them have that experimentation and rest and competence to say, I matter, my no matters, is huge in building the agency of those little people.
I look back on the therapy that I used to do, and it does break my heart. I was the queen of all things that vibrated and overstimulated. And I distinctly remember dipping a vibrating stick in mayonnaise. And while the child was on a beanbag pillow on the ground because we couldn't sit up, and vibrating her face and her mouth, and her mom was like, "What are you doing?" I was like, I'm waking up her face, and we're trying the condiment. And I do love me some condiments. And she goes, "I hate mayonnaise. Also, she's awake. Why isn't her face awake?" And I literally, I freaking kid you not, I stopped and was like, and I looked at this mom, and the mom was maybe 2 years younger than me, and she was sass pants is how she was kindred spirit. She reminded me so much of myself, and I was like, I actually don't have a good answer for anything that you just said, and I'm not quite sure what the hell to do with that, because I knew her really well. And she goes, yeah, can we do something different? And I was like, yes.
Good for her.
She was attuned and attached to her daughter, and I was not, nor should I have been, because I was new to them. But also, I could not stand on any body of evidence to justify truly the actions I was taking, aside from I had seen a clinical supervisor do this to a child, right? But there was no intrinsic motivation. There was no, it was I'm deciding and I'm doing. And folks, when we're mentoring the younger generation, because if you are in pediatric feeding disorder, please, please, please do not be a gatekeeper. Please, please, please take on a student. We have to grow. Bless you, dog. Sorry, dog is also home with me today. But we have to take on the next generation and mentor them in what we were missing. But what I get asked a lot by the younger clinicians is, but I have to chart growth for billing. I have to be able to document skilled clinical intervention, which then turns around, and this is why we have to write beautiful plan of cares with nuanced goals that truly understand what responsive feeding is, what autonomy is, and what trauma-informed care, because we don't have to write a goal that they're going to take 10 bites.
Yeah. And I have never, ever in 25 plus years of working, I don't even know how many years, with feeding and swallowing, I've written a million different goals in a million different ways.
Yes.
Nobody has ever questioned my goals. Never.
Knock on wood, but also same. Also, can we just acknowledge the goals we write now versus the goals we wrote back in the day? Oof, those are two very different things.
Holy moly. So different. So different. Well, in our program, we don't have to write goals
Nice.
the same way, which is nice. But sometimes we do, like, our goals will be things like, and Marcia Duncline has a great course on goal writing, if anyone's interested. But I think one of the things that we've put is in there is that so-and-so will show comfort at meal times by participating with his family. So-and-so will be exposed to X opportunities to interact with food with his family. Like, there's so many different ways to do something that you can measure. You can measure, they used to sit at the table for 5 minutes, but now they're comfortable enough to stay for 15 minutes without anybody doing anything because the structure that we put into place made them feel safe. We do need to show progress, for heaven's sake. Of course we do. But that doesn't mean it has to be what we decide is progress.
Yes.
And it doesn't have to be a set number of bites or intakes. And of course we care about weight. Of course we do. We want kids to grow. But we also, with any medical intervention, we're looking at the pluses and the negatives. You were talking about readiness for tube weaning. And so we have a student right now, and she was asking why our goals are so different than a lot of other places. And I was like, well, when these little babies are teeny weeny and they're fragile, the biggest measure of wellness we have is their weight. Until they're a certain age, that's really the main thing. They're not doing much else. They're breathing, they're pooping, they're gaining weight. Like, that shows wellness. But once you reach time when they should be doing other things, in fact, after a certain point in age, and I feel like it's pretty young, it's less than a year, if you give them extra calories, it no longer translates to cognitive development. They get better gross motor skills, but not better interaction skills and not better cognitive scores. And so if we're viewing weight as the main indicator of this kiddo is doing well or not, we're missing the majority of their life and the majority of their body systems and the majority of their brain development, the majority of the world they're sitting in. And so I think it's too easy. Like, again, are we worried about 5 extra calories, or are we worried about a sense of agency and autonomy? Like, can this get the other? That working with making them eat does not develop their agency, but working on their agency can help them become better eaters. So we do have things we're working on, and it doesn't have to be calories. It's trickier.
Yes, they are.
Calories are easier.
Then you hit the other side when they're bigger and they only want to eat McDonald's chicken nuggets or one type of French fry or one sweet. And yes, they will put calories on. But are they actually metabolically nourished? Do they have enough vitamin D? Do we have then it's a it's almost like the pendulum swings the opposite direction. Yes.
The other way. Yeah.
I had a thought and it's gone. It will come back to me. Huzzah for ADHD. There's that. Oh, it's back. One of the things I've started doing. So my girlfriend Melissa from Mississippi, because I feel like you have to say Melissa from Mississippi. Like, this is yes. It's actually Melissa Davis.
Awesome.
She owns Kid Spot Therapy down there, and she's wonderful, wonderful human. One of the things that she talks about is a phrase, store to table. Instead of farm to table, it's store to table. And are we getting kids involved in the continuum of experience, or are they just plopping down at the table? And over the last several months, I've actually started in on, well, let's have the tiny human pick the menu. Like, go to the grocery store, how are they actually engaging in meal prep or cleanup if they're, not able to do. And one of the beautiful things about working here in the Valley is that I have found a higher proportion of my patients either break bread together. I didn't see this in Columbia. It's a regional variation, which I did not anticipate. And the table might be a coffee table, the table might be the bar counter, but they're eating together more as a family. And watching that navigation has actually improved attunement and attachment by just having those little subtle changes
Mhm.
of being together. Yeah.
Right. Mhm. I think one of the things that we've seen, again, we were talking about the difference between being in a
Yeah.
clinic and, like, being in their
Yeah.
homes like I am now, and I knew a lot about feeding and swallowing. I knew a lot about medical systems, working with stroke patients as adults and then craniofacial clinic. Like, I had lots and lots of medical knowledge on lots of weird diagnoses and problem-solving pathways.
Yes.
Rehab is awesome for the problem-solving pathway. If you've never worked in rehab, to see this thing come in and to see the doctors kind of navigate through what the possible difficulties can be with adults, because super helpful. I didn't realize how much I was missing
Yes.
of this little person's life. There was so many factors at play, from how they get to the table, from how they view food, from how their parents view food. Are they sitting at the table and expecting their child to eat meat and veggies while they're drinking a protein shake? Like, that's
Yeah.
helpful to know in what their child might have
Mhm.
learned about food, because we know that there's actually a lot of data
Yes.
talking about how kids eat what their parents eat. And that's their first teacher of food. Of course they eat what they eat. They're supposed to. But then
Yes.
remembering that we need to eat what we
Yes.
want them to
Or
eat,
or the
you know?
impact of a sibling. I'm telling you, out outpatient clinic,
Yes.
I
Oh,
thought I
magic.
had it all down pat, and then I went into the house and the sibling showed up and was like, "Ew, that's disgusting," or "I'm not touching that," and it was like all of a
Yes.
sudden the kid just shut it down. But how
Yeah.
and then
Yeah.
finding out that, "Oh, you might not be the only little one in this family that also has." Yeah,
Correct. Yes. Yes. But do you know what is magic? Is
cousins.
cousins. Cousins that are a
Oh, cool
little bit
cousins.
older,
Yeah.
that you can talk to them and they understand. Like, you can give them about 2 sentences on, you can't make them do it, you can show them what
Yes.
to do, and don't shame them, basically. Cousins are like those little people that are just one size up. Brothers and sisters too, but they can be kind of annoying. But cousins, because they're
Uh-huh.
also often
Yeah.
a little bit
Like,
novel,
I have one little
So
friend
amazing.
who I've been working with for a while and would do anything Shell did, imitate Shell, got home, and there was no other tiny humans. I mean, I'm a giant cartoon. You know what I mean? Like, I'm there, bright colors, the whole
Yeah.
nine yards.
Yeah, for sure.
However, the family just had a new addition. Another family member moved in with them. Same
Uh-huh.
aged peer. Same aged peer. Novel, advanced eater, exciting, and just a passion for life
Yeah.
at 3, which it's it's like
Yeah.
baby girl's gonna be a firecracker, like, just watching it, right? Let me tell you what,
Yeah.
watching that,
Yeah.
it was like a light bulb went off, and it
Yeah.
opened the little one I've been working with. He became motivated to do what new family members doing because we're seeing it modeled and we're excited. And we
Mhm.
also have a friend. And friendship is such a powerful motivator. Yeah.
Right. For sure. And I think, we were talking
Yes.
about being communication specialists and healing
Yes.
family relationships. I feel like it's super incumbent upon us to do everything we can as kids get older
Yes.
to help them fit into their peers, with their peers. If all they eat is a snack bag of goldfish crackers and that's what they can bring to participate at the birthday party, send them goldfish crackers. Don't highlight what they're not doing around everybody else. What can you do? Maybe send goldfish crackers for everybody. Like, what can we do to help people feel like at the level that they want to be? Not every kid wants to go to a birthday party, but do they not want to go to a birthday party because they're ashamed of what they're doing? Or do they truly not enjoy interacting? Is that overwhelming and overstimulating? I think it's often that we go to, it's overwhelming, it's overstimulating, they just can't do it, instead of doing a little bit of detective work and finding out that maybe they're ashamed, or it feels like it's going to be too big or too hard or too high. And what can we do to level the playing field instead of protecting them from that or forcing them into something different. I think being their best supporters and cheerleaders, I think is huge.
My husband and I just navigated this with our oldest. His middle school has a series of Friday fun days or something like this, where they have like a big party after school, and you have to like pay $15, and it's all you can eat, all you can drink for like kids, right? And he's Goose is neurodivergent, and he's like, I do not want to go. And he is my sensory, like if it's too loud, if it's too big, we're out. And so we dug a little bit, created the safe space. We're not going to make you go, so don't worry about that, but help us understand. And it was, he wanted to hear from his friends what the first experience was like. Instead of jumping in, he needed to hear it to process it. And then maybe I'll go to the second one. But he's also the kid that doesn't like birthday parties because it's too much. So I'm like, I could understand how a bunch of 6th, 7th, and 8th graders running loose in a cafeteria could be overstimulated. Also the smells. Oh my God.
Ugh. For sure.
Yeah. So especially at the end of the day on Friday. Ugh. Yes, I too understand Goose danger, but no.
Ugh.
Okay.
Yeah. Not good. Yeah.
So if we're respecting our tiny humans, I love that idea of sending in the goldfish crackers. That's brilliant. This ties into from intrinsic motivation into responsive feeding. And I know that you are coming to Asha to do an invited talk on it because you are a goddess. So thank you.
I am.
Yes.
I'm so excited about that.
I was office chair and worked with the committee, and we were able to put out an invitation to have Heidi come and talk about responsive feeding and tube weaning. It's too many words. It's tube weaning protocol, like all of the words jumble up.
Yeah.
Take
too
us
many
through
words.
kind of what how these two interconnect, and do you know what day you're presenting on? Do you have that information yet?
I should have that presentation, and I do not, but I can get it to you. So I'll look. It's in my calendar, so I can pull it up. So I think one of the things that we found, and when I put some thought into this talk, and it was a quick turnaround time, but I feel like what's missing is, number one, tube weaning is kind of glamorous. Everybody likes the idea of tube weaning, and it's life-changing. Like, y'all, it's like magic. Doing this and seeing this progression for these kids is just, I'm still friends with people I worked with, their kids like 10 years ago. I still get posts of things. Like, it's that life-changing for them. But I feel like it's often done in clinics with teams, which is fine. Like, I'm not opposed to clinics and teams for tube weaning, but that's not where the majority of our clinicians work.
Yes.
And that's not where the majority of our kids are. States, there's very big states. There's tube weaning programs at the children's hospitals in each state. Like, that's just a really difficult transition for a lot of families. And so the focus of my talk is how to heal kids' relationship with food in preparation for that tube weaning. Anybody who touches a kid with a tube, every touch matters. Every interaction matters. Everything around food matters. What can you do to make it matter in a positive way for that child? So we'll talk a little bit about our tube weaning program and how it works, and the motivators that we use, how do we elicit some of that intrinsic motivation for kids. But I think the intent is really for any therapist who touches a kid with a feeding tube, how can you be a part of getting them ready for that next step, whatever that may be? And we've talked about that before. Lots of different things and situations tie into preparation for all of that stuff. And so really trying to take it, because if you do it well before you get to the tube weaning phase, you might not actually need an intensive program. You might be able to do it without that because you've normalized that relationship with food with them. And so that, I think, EI therapists, clinic therapists, people who are interacting with therapists long before they're ready for that intensive team can all play a role in helping prepare them. And so that's really the focus on that, is how do we get these little people ready for that? And if they do need a team, great. Then they're ready for the team. And then their transition with the team is a lot easier. So how do we pave the way for them to get ready for this next step? And I do have another talk for those who are interested that's on responsive feeding and some of the evidence for responsive feeding. So it really goes through a lot of the studies that it's not responsive feeding
Not as much
therapy.
as
It's
we
what
need
does the
to.
world know about responsive feeding, so that you can look at it with some new eyes and say, does this apply to my kiddo or does this not apply to my kiddo? Is this some information that's helpful I can take back to this family for their mealtime?
Yes.
And so really starting to look down that road a little bit too. So those are the two things. And I think we have a poster too on the outcomes of our program, but I'm not sure about that because I know we're doing that AOTA too, and I could be confused
having been
now.
an early intervention SLP for years, I was on the receiving end of where there was like a turf war, like almost. And that doesn't need to be a turf war. We're all in it together. But I was also on the receiving end where we couldn't find partners to initiate tube weaning. And that was often very, very difficult when you have a child that's demonstrating readiness, you have a child that's demonstrating intrinsic motivators, and they want to eat, but they're so full because of their
Right.
feeding schedule that can't give them there's only so much space to put so much food in. And y'all,
Right.
you have to learn how to be an empowerer and an advocate for your caregivers, so that if you are in those settings, if you're in early intervention or if you're in an outpatient private practice setting and you're the point of contact and there's no other SLP there to help, how do you work with pediatrician or GI or RD to say, look, we are ready. How can we work collaboratively to start cutting back on, the volume feeds that are getting added? And that was so scary, so terrifying when I first started in this world.
Yeah. Well, and Michelle, you and I are both not.
I think you called me old, Fred, and yes, ma'am, that is accurate.
One of the things I've learned in my journey is how to advocate in a professional way as a collaborative team member. And not, would it be okay if we cut the tube things a little, of coming to the table and saying, I am a team member. I have seen that when he is tube fed at this rate, that he throws up more. What do you think, given the importance of eating by mouth, given the importance of self-regulation and learning how to eat, what do you think? Or like empowering the families, the moms, to not go in and ask permission for things because if you ask for their advice and if you ask for help, they're going to give it. That's their role. And so if you can empower them, like you said, to come in and say, I've really seen that he always throws up after his morning tube feeding, and he usually eats a pretty big breakfast. I'd like to see if we could reduce his breakfast feed or take his breakfast feed out. What's the best way for us to do that and keep him safe? And so really having collaborative conversations in a way, and again, you also need to know what you're doing. I also don't want to empower. When I think of some of the things I advised back when I was first a clinician, I was like, what was I thinking? So it's knowing your own limitations as well. And if you think they're looking like they're ready and you're not feeling equipped to do that yourself, then there's no shame in saying, I'm not quite ready for this yet, and helping them seek some different advice. But I think also remembering that feeding a child is a parent's job. If they were taking a bottle, they would be making the decisions on what time they were taking the bottle, how much was going in the bottle, when they were stopping the bottle, or the baby food. Like, that is a parental role that we would like to build parents' capacity to do that well. And so again, it's like easing the transition between a medical tube intervention to family mealtime decisions, and how do you empower the family to have those conversations. In our role, we get to talk to the team members. I know early intervention, it's not always you who speaks to the medical provider, but you can sure coach the parents to bring it up in a way. I don't want to burn any bridges. We need good medical providers for our kids. I don't think it helps to just go against your medical team. But if they're not listening to you consistently, then I wonder if it's the medical team that you're comfortable with, and maybe it's time to continue to seek
the power
guidance
of a
from
second
someone who would listen to
opinion
you.
and the power of knowing roles and responsibilities and scope of practices. And that's where it gets back to our code of ethics. Because I know in South Carolina,
Yes.
they have the early interventionist. And one of the things that I ran up against was that the early interventionist was a non-licensed professional. They were not even certified as teachers. Therefore, they cannot
Right.
communicate my plan of care or my concerns to the pediatrician because that's not their scope. Bless. Some of them, I had individuals
Right.
who had sociology degrees that were acting as early intervention. I'm like, oh, honey, you mean well, but
Oh,
yes, but we.
you
Well, oh,
have a
honey,
good
I have
heart.
said that.
Bless your
There is
heart.
a direct correlation between the amount of times you get blessed and the amount of times this eyebrow right here is real thin because I mess with it when I'm really stressed. So, also, I was a teen in the 90s and I overplucked, but I digress. That being said,
Yeah, fair.
knowing your scope of practice and your roles and responsibilities. So, if you are in early intervention, if your team coordinator says, oh, that's my job, you can advocate. Yes, and I hear what you're saying. However, I can't allow you to present this to the specialist because that's not within your role. And I need to make sure that this is conveyed such that
Right.
the feedback given I can ethically implement. And I know, because at the end of the day, it's also our license. And so
Right.
and y'all, every state is different. So you need, for those of us that, yes, it does. And not every state
And it
gets access
changes
to
a
medical
little.
records. Here in Virginia, we don't get automatic access to medical records in early intervention, which when you find out that the
Right.
child you're working with has a cardiac component after you're seeing the child in your eval, or you find out that, oh, by the way, they have Down syndrome,
Right.
and that wasn't involved on anything, and you just happened to notice when they came in for their eval, that's going to change what you're doing. So this is, very, very impactful.
Yeah. Well, but I always think there's value, if possible, to empower the parents to do it, because I'll do it if I need to.
Yes.
But I'm not going to be with them forever, nor should I. But helping the parents and coaching the parents, because let's just say that we've gotten them off the feeding tube and they're eating 15 foods. Best they've ever done. That's amazing. If they were to go in and say, but they're only eating 15 foods, is that okay? Then you're going to get a well-meaning doctor or dietitian who's going to say, you know what, actually they should have 20, which I can't even tell you how many families are like, it's just so sad because they're so excited that they're eating 15 foods, but somebody well-meaning kind of just stomps on it. But coaching them instead to say, this is awesome. He's eating 15 foods and he's trying something new every day and he's still liking things. That's amazing. And then you get a different response from the medical provider. And so really coaching families that they're not asking permission and they're not going to the principal's office. It's important how you present it because medical professionals care and they rely on parent feedback. And so if the parent comes in thinking there's something wrong, they're also going to think there's something wrong. And so helping them see the power of their words and bolster their confidence.
Equal stakeholders.
As well.
Caregivers are very much
super
equal
important.
stakeholders in their child's care. Yes.
Yes.
Okay.
For sure.
This was awesome. Thank you so much. I feel like we have barely scratched the surface and I would love to have you back.
So much. I will be happy to be here. It's so fun.
Somebody wants to learn more from you. How can they reach you?
Of course. The best way is probably to email Erin at thrive@spectrumpediatrics.com because she's the gatekeeper of all things. But they can also look at our social media is not super active, but sometimes we have stuff there. We have courses at the Get Permission Institute, which is Marsha's, the Chicago Feeding Group, and RF Pro. We're redoing the foundational series on responsive feeding, which is a fantastic thing that has Katya Rowell, who's an MD, Joe Cormack and Hazel are both counselors, And then Jenny, my colleague, and I, she's an OT, and I are doing some pieces of it. So that's a huge course that has lots of stuff. And we are actually starting another mentoring course in like a 4-week mentoring course beginning in October. And then I think we'll do another one in January with a focus on responsive feeding. So people can check that out on our social media.
Kindness. It's profound.
Okay.
Yes.
Thanks.
Okay. Folks, as
So
always,
fun.
come find Erin and I
love it.
Erin Forward and I on First Bite Podcast on Instagram as well as on Facebook. And if there's a delightful speaker that you would like to hear from, please message us on Instagram and we will take a peek. Heidi, thank you. Thank you.
Sounds perfect. It's been a treat. Thank you so much.
Thank you for joining us for today's course. To complete the course, you must log into your account and complete the quiz and the survey. If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete mailing address in your account profile prior to course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to reflect on your ASHA transcript. Please note that if this information is missing, we cannot submit to ASHA on your behalf. Thanks again for joining us. We hope to see you next time.
Feeding Matters guides system-wide changes by uniting caregivers, professionals, and community partners under the Pediatric Feeding Disorder Alliance. So what is this alliance? The Alliance is an open access collaborative community focused on achieving strategic goals within 3 focus areas: education, advocacy, and research. So who is the Alliance? It's you. The Alliance is open to any person passionate about improving care for children with a pediatric feeding disorder. To date, 187 professionals, caregivers, and partners have joined the Alliance. You can join today by visiting the Feeding Matters website at www.feedingmatters.org. Click on PFD Alliance tab and sign up today. Change is possible when we work together. That's a wrap, folks. Once again, thank you for listening to First Bite, fed, fun, and functional. I am your humble but yet sassy host, Michelle Dawson, the All Things Peds SLP. This podcast is part of a course offered for continuing education through speechtherapypd.com. Please check out the website if you'd like to learn more about CEU opportunities for this episode, as well as the ones that are archived. And as always, remember, feed your mind, feed your soul, be kind, and feed those babies.
Hey.